I would like to welcome now to the stage our second speaker. For today is going to be Dr. Namrata Chandhok with her talk, A Chip Off the Old Myeloid Block, What Expanded Somatic Blood Cell Clones Can Mean in Our Clinical Practice. Dr. Chandhok attended the George Washington University School of Medicine and completed her internal medicine residency at Tufts Medical Center in Boston, and then her clinical fellowship in hematology and oncology at Yale University School of Medicine. During this time, Dr. Chandhok participated in research focusing on novel approaches for targeted tumor chemosensitization, particularly in isocitrate dehydrogenase mutant AML and MDS. Dr. Chandhok was awarded the Hematology and Medical Oncology Fellowship Program Research Award for outstanding research in hematology for her work. Dr. Chandhok joined the University of Miami as an assistant professor in clinical medicine in the Division of Hematology. Please give a warm welcome to our Dr. Chandhok.
Hi, thank you. I just want to make sure, can everyone see this in a full screen mode or you're seeing?
No, we're seeing your slides, all your slides.
Okay, great.
But not in full screen. There we go.
Perfect, thank you. Well, good afternoon, everyone, and thank you for having me. Today I'm going to talk about basically clonal expansion in the blood compartment and mutated hematopoietic cells, and how this would affect a lot more than just my area of interest, which is the myeloid malignancies. So this case is slightly made up because I haven't been here long enough to have the longevity for this, and some of these cases tend to be more complicated than this is, but basically the points in the case will demonstrate the topic of today. So it's Friday afternoon, and it always is Friday afternoon for us, and we have a 71-year-old Caucasian man who comes to clinic complaining of fatigue and dyspnea on exertion. And his past medical history, he's pre-diabetic, he's overweight, and he has a history of 2 MIs in the past. He used to be a smoker, but quit a very long time ago. And he's a model patient with regular follow-up with his PCP and cardiology, and was last seen in clinic about 5 months ago. So at this time, on his labs, you're going to see leukocytosis with a white count of 37, an anemia with a hemoglobin of 9, and thrombocytopenia with a platelet count of 100. And a few minutes later, the differential pops up and you see that he has 78% blasts. Now, you do the absolute perfect thing and call me right away, and we admit him to the hospital for treatment. And as a part of the workup, we do a bone marrow biopsy, which has a normal carrier type, but we also see a TET2 mutation, which puts this patient at intermediate risk disease in the AML world. We give him the best available therapy, whether that's trial or induction, and he's scared, like all cancer patients and leukemia patients are, and ask you, doctor, how long do I have to live? Now, unfortunately, even in 2020, despite all the progress in the field, since he's 71, he's unlikely to make it to his 75th birthday, and I think I wouldn't be incorrect to say to his 73rd birthday in the majority of cases. So we look back at his CBC from a year ago for comparison, and his white count at the time was normal, 6.1. His hemoglobin was slightly lower at 12. His platelets were 325. But you do see that his MCV at the time was 105. So could any of this information have told us something earlier? So going to the many roads to AML, very broadly speaking and oversimplifying, cancer is a result of stepwise acquisition of mutations. And when you hit the right cell with the right mutation in the right environment at the right time in the right order, this leads to the development of myeloid leukemia. And then once you have an initiating clone that's not differentiating and expanding, it creates clonal subgroups, and then there's a battle of fitness between these subgroups. But not all leukemia evolves the same way. So for example, your younger, fit patient with no comorbidities frequently take the most direct route or go straight to de novo AML, meaning they acquire these mutations in a pretty quick order. And while this disease, while this is, you know, an aggressive and deadly disease, even in this situation, it's a lot more curable. On the other hand, you often have patients who are older, who have multiple comorbidities. You know, over the course of their lives, their bodies have seen multiple stressors in the form of chronic illnesses, and they develop these abnormalities in their blood, which are not enough to cause anything significant, but these abnormalities smolder. And over time, they pick up more and more abnormalities, and this eventually creates, like I said, the right order, the right environment, and the right situation for you to develop leukemia, often by way of MDS. And this is, or Myelodysplastic Syndrome. This is much more deadly and difficult to control. So just simply speaking, oftentimes, I think there are two camps of people who see MDS and they think, oh, no big deal, just a precursor to leukemia. And, you know, other people are like, oh no, let's talk about palliative care right away. So MDS is a huge spectrum of diseases, but realistically, to meet the definition of MDS, you need to have a documented cytopenia over time. So a hemoglobin less than 10, an ANC of less than 1, or a platelet count less than 100. But you also need at least one of the following. You either need to see, you know, significant bone marrow dysplasia, that means more than 10% in the marrow, or you need to see an increase in your blast count, which, you know, is the easiest metric realistically for us to follow, but is not always the case. And finally, you could have a characteristic cytogenetic abnormality, like monosomy 7, which would put you in this class of myelodysplastic syndrome. But like I've been talking sort of the whole time, I've used the word mutations many times, but mutation shows up nowhere in this definition. And this is because we're still in the field catching up to scientific discovery. And the transition to clinical medicine often takes much slower and more calculated steps because obviously there have consequences outside of the lab. So when people don't meet these definitions, we still need to be able to substratify them so we can, you know, treat them better and maybe catch things earlier, figure out, you know, who's sick and who's going to get sick earlier. Now, within AML, over the course of the last 5 or 10 years, we've really been able to stratify risk in terms of who's going to do well and who's going to do poorly by looking at a huge number of patients. I think it was close to 1,600 patients in this study, which is a lot for AML, and figure out, you know, what carries the biggest risk. So, you know, in the past, we've known for decades that having a mutation in a gene called P53 is bad. But this paper helped us basically put this into perspective, like what's really bad and what is, you know, sounds bad, may not have the same consequences. So on this graph, in this figure, you see basically survival, and anything on the left of 0 is basically slightly better risk, and anything on the right is slightly worse risk or worse risk. And then the higher up it is on the curve is the higher the better the p-value, so meaning how significant it is. And then finally, the size of the circle represents the frequency, so how frequently it's sought in this subset. And so you see things like age, high white count, like I'd mentioned, the TP53 or FLT3 mutations, which you very commonly see in leukemia as bad, showing up exactly where we expect to see them on the right-hand side. But what happens when we see these mutations in what we quote unquote would call healthy people? And that's going to be the topic of the rest of my talk. Because this, you know, we're finding out more and more within the real world has consequences outside of hematology. So there are lots of new 4-letter words in our notes that you'll be seeing, and basically how we define them or why, you know, I want to go through the definitions a little bit so they make more sense. So if you see just cytopenias, but there are no dysplasia or no clonal mutations, this is something called ICUS, or idiopathic cytopenia of uncertain significance. Now, fortunately, at least to date, we don't know of an increased risk in this situation for a hematologic malignancy. So if I saw this patient and they just had low counts but no mutations or dysplasia, they don't really, as far as we know, have a higher risk of developing leukemia or MDS. Now, if you have a clonal mutation, but without a significant cytopenia, like we had defined earlier, platelets less than 100, hemoglobin less than 10, you have something called clonal hematopoiesis of indeterminate potential. And this is a very, very interesting field, which I want to discuss in great detail. The last category is when you have cytopenias and a clonal mutation, but you don't meet the definition of MDS because you don't have dysplasia. And this is something called clonal cytopenia of uncertain significance. Now, this is a big red flag for all of us because these patients have a 16 to 20-fold risk of developing a hematologic malignancy. So even though by our classic definition, they don't fit into the box of MDS, we have to take this pretty seriously and watch them very carefully because their risk of developing something deadly is quite high. So going back to clonal hematopoiesis of indeterminate potential. So CHIP, which is the easier name, and it's also called ARCH in Europe, is a cancer-associated clonal mutation with a variant allele frequency of greater than 2%, which is what we think of as the practical definition because we all have small clones that emerge, but they're only significant above 2%. In the blood of healthy people without a known hematologic malignancy. Now, bringing it just back to the case that I described, it's likely that our patient might have had this, and nothing was missed because this wasn't something we routinely do or even routinely do right now. But I hope, in 10, 15 years from now, this is going to be a standard thing to look at and we can give him a diagnosis and, help risk reduce as best as we can and intervene. So basically, CHIP occurs in 1 in 10 individuals over the age of 70. So most people over the age of 35 or 40 already have started acquiring mutations, and you acquire about 1 to 1.5 mutations a year. So a lot of this audience probably starts to have some of this, but it only really starts to matter or show up in that VAF, the allele frequency, like I talked about, in older individuals over 60. And basically, we're seeing that, like I said, 10% over the age of 70, it is about 12% in patients over the age of 80, and close to 20% in patients over the age of 90. So it's significant, and it's in a lot of the patients we see here. And so what's important here is that beyond just the hematologic malignancies, patients with CHIP mutations have a 1.4-fold risk of all-cause mortality. So in this figure that you're seeing is, if you see all the red lines are the patients with the clonal hematopoiesis, the Kaplan-Meier curves. And the black lines are patients without, and you can see there's a clear separation. Now, it's more significant in the patients over the age of 70, which we expected, but it exists pretty much in all patients that carry this. And so this paper, which looked at thousands of patients, basically saw that people with a somatic mutation, a CHIP mutation, basically had a increased risk of hematologic malignancy, like we expected, about 1% per year, which is not very high, but also an increased risk of myocardial infarction and ischemic strokes. Now, characterizing this a little bit better, so this is becoming a growing literature in the cardiology world as well. CHIP has been associated with cardiovascular disease. So in this figure that I'm showing you, which will focus more on the A and C, they looked at mice and development of atherosclerosis. Now, the only thing that they did extra on top of having a CHIP mutation was that they had to nullify the LDL receptor, because without that, mice don't live long enough to develop significant atherosclerosis. So they basically used LDL deficient mice, and in the wild type, they gave, wild type is wild type, but in the knockout, they knocked out TET. And if you can see in the 9-week figure, the color figure, basically, you can see there's much more atherosclerosis, and it's been quantified in part B. And then just looking more grossly at the wild type versus the knockout, or even the Het, you can see much greater accumulation of plaques in the knockout and the Het. So this shows us quite definitively that TET mutations can lead to increased formation of atherosclerotic plaques, which would support the data that we've seen in humans. Now, we're starting to get a better idea of what happens mechanistically in this situation too. So atherosclerosis here was thought to be due to an increased secretion of interleukin B by the TET2 deficient macrophages. And so this basically activates your inflammasome, and you have a more inflammatory environment. So it affects your endothelial interaction of the blood. And other studies have shown that, the lack of TET actually leads to higher expression of many inflammatory mediators like CXCL1, 2, and 3 when exposed to bacterial endotoxin and such. So we do know that, basically these people are at baseline more inflamed. So where else is this important outside of the leukemia world? So I wanted to give a disclaimer that obviously, the first discovery of this was about 5 years ago. So we're still in that experiment and association finding phase. But realistically, all these acquired mutations are seen in immune effector cells like the monocytes, your granulocytes, your lymphocytes, and this can create an altered immune state in general. So in allergy, there's been some literature that having the lack of DNMT3A, which is also a CHIP mutation, leads to more robust allergic reactions with higher levels of IL-6 or TNF-alpha. In pulmonary, it's a little bit harder to say in this situation because most of the patients that they were trying to associate with COPD have a long history of smoking, and smoking is bad for you in other ways, but also creates CHIP. But when they were controlling CHIP versus non-CHIP, they saw higher cytokine profiles, basically. And this is just one small study, so a lot more to be explored here. And then in the autoimmune and myelodysplasia, we know that there's been a relationship for a very, very long time between autoimmunity and having a hematologic malignancy. Now, CHIP is rarely seen in the B and T cells itself, which drive a lot of autoimmune disorders. But there is a clear effect on that we're starting to see now. And there was a study that actually showed that 30% of patients with ANCA vasculitis had a CHIP clone. But the caveat here was that there weren't actually normal controls without the vasculitis in the study. So they weren't looking at truly wild type, but within their population, it was highly enriched. And then within neurology, they're starting to find links with Alzheimer and Parkinson's as well. Now, again, this is not a very thorough investigation thus far, but within whole brain DNA of elderly patients, they've seen that, there's a TET2 and a DNMT3A mutational enrichment. So all of these are kind of clues that your blood is actually affecting pretty much all your organs and inflammation. The biggest and most established relationship we have so far is not necessarily just in leukemia, but in cancer survivors. And traditionally, when we see secondary leukemias, we think the chemotherapy caused all those additional mutations and we can blame that. But we've also seen, and there's data to support this, that the chemotherapy actually just leads to selection of some of the abnormal clones because they have a fitness advantage. And so, within cancer patients, you'll select for patients with the particular mutational profile like TP53 or CHEK2 or PPM1D, which are all CHIP mutations, but are also essential to the DNA damage repair pathway. And this eventually leads to development of leukemia. Now, beyond this, we're also starting to see that, not even within chemotherapy, there's a big difference. So within just the class of the platinums, if you check the difference between carboplatinum and cisplatin, carbo actually has much more CHIP enrichment than cis. So a lot more to come here, and this will affect our decision-making, or should affect our decision-making with regards to chemo in the oncology world in the future, because a lot of times the easiest mentality to take is more is better, but that might not actually be the case. So big questions we have in leukemia is, CHIP is common and leukemia is not. So can we identify patients who will develop pre-leukemic clones and risk factors that will promote leukemogenesis? And this is somewhat ongoing work where, we learn lots of new little chips of data every day. And then how do we catch this early and prevent clonal evolution? It's not clear, but lots of places to look at prevention. So we do have drugs that target some of these CHIP mutations, but is early drug use really going to help us, or is this something we still have to figure out? And then how does this affect our thinking regarding, transplant donors in leukemia? So we know that, older patients with CHIP mutations have poorer engraftment, and you can actually have a donor-derived leukemia risk for patients if they have these mutations. So some centers are actually screening for this, and we try to restrict older donors anyway, so like over the age of 60, but this is becoming more and more important. It's also becoming more important in the world of cellular therapy, which we hear about a lot these days. So with CAR Ts, they're looking at how they can knock out certain clonal mutations like TET2, because they've actually seen that can reduce your T-cell exhaustion in that situation. So a lot more to come in this realm here. But because, like I said, very prevalent and large numbers, we need to have a lot more information to find who's actually getting leukemia versus not. So just looking into like that one question of what clones are pre-leukemic, we do have some clues. So I mentioned, certain types of chemotherapy affecting more or less, but the figure on your left-hand side basically shows that with chemotherapies like cisplatin, which is commonly used in the oncology world, this chemo basically causes selection of this mutation called PPM1D. And this is driven basically because the CHIP clones have less apoptosis to the chemotherapy itself, so there's a selection advantage compared to the wild type cells that end up losing. Now, I say these words like DNMT3A or TP53 and CHIP, and it's a nice general statement, but where the exact mutation is also makes a huge difference. And what we're learning now is how do we stratify a mutation? So all mutations, for example, in DNMT3A are not created equal. And if you look at the central figure labeled A, you'll see each specific mutation and how they did a very large computational study where they showed not just what gene, but what base substitution within the gene will cause the biggest disadvantage to a patient and eventual development of leukemia. So in this situation, we're starting to learn using other variables such as your variant allele frequency or how big this clone is to find out, how we should tailor therapy further. So lots more to come in this area. As you can see, this is all really new. Like the paper about the cisplatin was from 2018, and this Watson paper was from earlier this summer, a couple months ago. So very, very new field. And the most important thing of this talk realistically is you guys are the front line, the internal medicine clinic, your cardiology clinic, the rheumatology clinic. Every single clinic here is seeing these patients. And now the question is, how do we bring them together? How do we figure out, to improve their quality of life moving further? So should we be trying to get rid of these clones, or are these clones just something that they have to live with? Should we be playing whack-a-mole in terms of trying to get rid of some of these mutations? And these are all things that we're going to have to figure out in the future. Now, just one important thing I wanted to say, like one of the things that they saw was quite associated with CHIP mutations is the development of macrocytosis. Now, as all of you know, macrocytosis can be for many, many reasons, like alcohol intake or a nutritional deficiency, other drugs that people are taking. So when you rule all of those situations out and you still have that, that can be a hint that this patient has a CHIP mutation. And I think one of the goals here for me anyway is to start a CHIP clinic to start affecting a more preventative approach, because once people develop a full-on leukemia, cat's kind of out of the bag. So treating them is much harder. But if we can take a preventative approach, we might be able to save a lot of lives. So like I said, highly collaborative field. I hope to work with all of you, and there's much to be learned about this in the future. Thank you for your attention, and I'm happy to take any questions that you have.
Thank you, Dr. Chandhok, for that very elegant presentation that was very clear. I wonder if you could comment on the background in which these mutations take place as to whether or not that confers susceptibility or not. For example, we know that there are certain normative values that are different in white blood cell counts for individuals of African descent versus non-African descent. And the question is whether we know enough about the genomic milieu in which these mutations occur that can also influence our understanding of their significance.
Great question. I think in a short version of that answer, I can say no, because this, like I said, this entire literature has been developed in the last 5 years or so. But what I can say is that at least in these studies, the 2 major studies that were done that first established CHIP and the mutations and where they pop up were done in Europe and here. So not necessarily accounting as well for other populations apart from just the minorities that were involved in this study. Now, if I'm understanding fully correctly, like you said, in African Americans, you often have like lower white cell counts and things like that. Those are sometimes actually related to certain mutations as well. And those aren't necessarily CHIP mutations. Those are other mutations like allele mutations or something that can cause that. So that's not something we're looking for routinely, and this is something we're gonna figure out. But they did do subgroup analysis with different racial or ethnic backgrounds basically, and it's not reaching significance, but there is some data.
Yeah, I mean, I think it's important because those of us that are non-hematologists that rely on normative lab values and ranges, when we see an abnormal CBC and we see a low white count, it really isn't attributing, these ranges are not adjusted for race or genetic background, and that could lead to some potential misinterpretation. But
of course, and I mean, I think that's why, 1, I'm here to help you, and 2, looking at the macrocytosis as opposed to an absolute count can help, because again, going back to just the definition of CHIP, you're not really going to see huge errors in your CBC. It's realistically just knowing that a patient is 1, older, and 2, you can't explain away a macrocytosis. And using the other factors like, again, my case was made extra beautiful. Dr. Weiss, I actually had a case with you, which would have been great, but it was too complicated.
Yes.
But this guy had a bunch of MIs. He has pre-diabetes. All of these things on their own are stressors, but independent of these outside stressors, we've seen that there's a specific risk associated with just the mutations.
Thank you. Well, I'd like to thank both our speakers today. One made us feel very how we should be happy, and the other one said, well, we need to be cautious and think about being happy.
Cautious and happy.
Right. Very good. So wish everybody a safe, wonderful day, and we'll see you all next week. Be well. Bye-bye.